Good morning to everybody. Welcome to Milano, which is, as you know, my hometown. We are going to discuss the interpretation of cardiopulmonary exercise testing, and I will do it from a cardiovascular point of view. Remember that my base is a cardiologist, even if I've been a fellow in respiratory disease in Seattle for many years and associate professor of critical care and respiratory medicine in Seattle as well. So I try to combine both the heart and the lungs. However, when we talk about cardiopulmonary exercise testing, we need to be grateful to several people, but two are the most important ones. Number one is obviously Professor Carmen Wasserman, who has been always a teacher for us. He has been like a pope, and he all the time say us, well, Mackie, you're doing this stuff, it's not totally correct, please change it. And he was always right. But what he teach us were mainly two things. Things number one is these gears, where we have here VCO2 and VO2 at the mouth, and here is what's happened in the mitochondria. The concept is that in between the mitochondria and the mouth, there are the lungs, the heart and the blood, the muscles, peripheral circulation and pulmonary circulation. And each of these can change VO2 and VCO2. So to be sure that what's happening in the mitochondria is what we see in the mouth, you need to have a steady state condition. And obviously exercise is not a steady state condition. However, the kinetic of changes of CO2 and O2 can be easily seen at the mouth. But remember, it is true only in steady state condition. The second thing that Wasserman shows us, among the thousands of things that he shows us, is why VO2 increase. There are three major mechanisms. Mechanism number one is an increase in oxygen delivery. And the increase in oxygen delivery is cardiac output increase and hemoconcentration. And the second mechanism is a reduction of PO2 in the capillary bed, up in the muscles, up to what is called the critical capillary PO2 pressure. And the third mechanism is the resistance to oxygen flow from the capillary to the mitochondria. Because also in here you may have a true resistance and difficulty for your oxygen to go from the capillary to the mitochondria. And remember that in the mitochondria during exercise, PO2 is very low and can be, according to Severenhausen, even negative, and the mitochondria act as hoovers. So to increase VO2, you have three mechanisms: oxygen delivery increase, reduction in PO2 in the capillary, and changes in diffusion for oxygen flow from the capillary to the mitochondria. The second man who we have to be grateful to is Professor Brian Whipp, and he is a physiologist. And he told us, remember that all the time you breathe, you have a ventilation, which depends on three factors: VCO2, which is the amount of CO2 production; PaCO2, which is the value of CO2 in the arterial blood; and the efficiency of ventilation, named VDVT. All this are under the sympathetic control, and patients breathe in a different way, but always according to this formula, so that you can plot this formula in a graph. On the vertical axis, you have VDVT. On the horizontal axis, you have the ratio between ventilation and CO2. And the line you see are iso-PaCO2 line, so line with the same arterial PCO2. The blue guy is a normal guy. During exercise, he reduced VDVT, he reduced VCO2, and only at the end of exercise, he changed the PaCO2, and the PaCO2 goes down. This is a physiology behavior of a normal subject during exercise. In red, you have the heart failure patients. They start with a little lower PaCO2 value, they reduce VDVT, they reduce VEV-CO2, but in a smaller amount compared to a normal subject. But the shape is the same. So blue and red have the same. The COPD here act differently. They increase PaCO2 during exercise, they increase VDVT, albeit they reduce VEV-CO2. The pulmonary hypertension guy, they increase VEV-CO2, they increase VDVT, and they reduce PaCO2. So if you can see these elements, three elements, VDVT, VEV-CO2, and PaCO2, and how they behave during exercise, you know what is the disease of your patient. Normal, heart failure, COPD, or pulmonary hypertension. But let's make a little bit of story of cardiopulmonary exercise testing. Here was the beginning with the Douglas bag collection, and then going back to the laboratory, or the big Douglas bag in the laboratory as well. But the beginning of the story, VO2 was seen as an hemodynamic parameter. VO2 was plotted against stroke volume or cardiac index, and patients were grouped according to different classes of VO2, but again, this was seen as an hemodynamic parameter. And you still have the Weber classification, class A, B, C, D, and E, with a VO2, max VO2 reduction progressively, and the same apply to VO2 at the anaerobic threshold. However, this concept was really debated when the results almost 30 years ago of the Veteran Administration Hospital studies on vasodilator in heart failure show up that there was no correlation between left ventricular ejection fraction and peak VO2. And so left ventricular ejection fraction was somehow stroke volume, and you say, well, how VO2 can be a hemodynamic parameter if it is not correlated with stroke volume? And that was the beginning of the change of the concept that we have in VO2. In the early 90s, Donna Mancini, we came out with this approach who said, if we have a VO2 at peak exercise and we are able to measure the anaerobic threshold, then we can classify our patient with high and low risk according to the value if it is above or below a magic number of 14. 10 years later, we came out with different values and prognosis, VO2 of 14, 14 to 16, 16 to 21, and more than 21, and this was considered important for prognosis. But most important, the Canadian group from Florida came out with the concept of a percent of predicted, because something is exercising a guy of 80 years old or a guy of 20 years old or exercising a lady or a man. In the early year 2000, we came out with the concept that if your peak VO2 was below 10 or greater than 18, you know that you are in a poor condition or a good condition, but in between, which is a great majority of cases, you have to look to efficiency of ventilation, and the efficiency of ventilation has a cutoff value at that time, which was 35, and if it is higher than 35, you are at high risk. Below 35, you put yourself in the middle risk. But you see that we have talked about anaerobic threshold. But in many cases, the anaerobic threshold was not identifiable. This is a paper that we did 10 years ago, showing that in a multitude of heart failure patients, the anaerobic threshold was not identifiable. There were more than 10% of the patients. And what we should do with these patients who reach anaerobic metabolism, but the anaerobic threshold is not identified, well, we find out, these are the blue guys, that these patients have a 5-year prognosis worse than patients with low, middle, or normal anaerobic threshold value. So no anaerobic threshold, but reached anaerobic metabolism is already a poor sign of poor prognosis. More recently, we did another study published in Chest in 2019, which says the blue are the guys with no anaerobic threshold and no respiratory compensation point identified. This was the prognosis. The red are the patients with an identified anaerobic threshold but not identified the second threshold, which is a respiratory compensation point. And the green are the patients in whom it was possible to identify both thresholds. This is regardless of the number. It's just the physiology of exercise. So if the physiology of exercise is preserved, you are in a good condition. If it's partially destroyed because you have the anaerobic threshold but not the respiratory compensation point, you are in between. And if you have both unidentifiable, then you are in a very poor condition. But another thing I would like to show you is that, we always say this is the anaerobic threshold. Well, actually, there are, in many cases, two anaerobic thresholds. And this study, this observation came out from this case report, which Brian Whip and myself published, showing that in a totally normal guy, there was a huge difference between the anaerobic threshold measured with the V-slope analysis, VCO2 over VO2, compared to the anaerobic threshold measured with the ventilatory equivalent of the end tidal of O2 and CO2. And this gap was thought to be due to a delay in the chemoreceptor response. More recently, we came out with this observation 2 years ago that in healthy subjects, in 10% of healthy subjects, you have a dual anaerobic threshold, so that the anaerobic threshold measured with the V-slope, which we call metabolic anaerobic threshold, was before the anaerobic threshold measured with the ventilatory parameters, so that it was delayed. But most importantly, this happens in patients with heart failure, and this happens in patients with heart failure according to the beta blocker treatment. These are patients treated with bisoprolol and carvedilol. When they are in bisoprolol, 41% of them have a double anaerobic threshold. When we are in carvedilol, 66% have the double anaerobic threshold. And they are the very same patient. So what is the reason for that? Well, the reason is that carvedilol is acting more on blocking the chemoreceptor response. So this was a clinical proof of what was going on over there. If we analyze a huge heart failure population as that in the MECI score database, I don't want to bring you through all this data, but these are more than 1,000 patients, you can see that you may find the double anaerobic threshold in 40% of patients. And in these patients, the second threshold have a lower VCO2, a higher end tidal CO2, and higher end tidal O2, a higher VVO2, meaning that the ventilatory response is not enough, is delayed. Believe me, it means that there is not enough ventilatory response. And this was a point which tells us we have to look at this, because this is a sign of chemoreflex activation, and probably of central chemoreflex activation. And you know that we have a bunch of studies ongoing in patients with heart failure looking to the chemoreflex response. But going back to VO2, we have to realize that the population we are analyzing changed over time. These are patients studied, the black ones, before the year 2000. The red ones are patients studied between 2001 and 2005, the blue 2005 and 2010, and the green 2011 and 2015. And as you can see here, even adjusting for VO2 and VEVCO2, the prognosis is quite different. This concept is most importantly, if you take the number, we say 12 ml per kilo is the limit below which you may be a heart transplant candidate, and you were studied before year 2000, your risk of dying in 1 year was 30%. If you were studied between 201 and 205, the risk was 14%, and in the most recent study, the risk is 8%. Still, VO2 is important, but you have to consider VO2 in the concept of your population, of your treatment, and if you have everything. So that means that it's necessary to check up all the cutoff value of guidelines and put them up to date. So what's happened, if we analyze CPET-derived parameter in our failure population according to age, gender, presence or absence of obesity, low respiratory exchange ratio, anemia, heart rate, beta blockers, cardiomyopathy, and so forth. Well, this study has been done according to age, and these are below and above the age of 70. The red one are those below, and the blue one are those above. And as you see, in both populations, VO2 has a prognostic role important. However, you cannot compare the same patient but with different age. Age is something that you have to take in account. The same applies to gender. You know that gender female have a prognosis which is much better than those of male. However, VO2 is lower. So how you match these things? Well, if you do a propensity score matching and you match men and women for age, VO2, left ventricular ejection fraction, and VEV-CO2, then the prognosis became the same. So again, you have to match subject with the different characteristics. Male and women are the same if you consider it age, left ventricular ejection fraction, VO2, and VEV-CO2. And what's happened if you have a guy who is obese and heart failure? Well, if you look here, total mortality, the green one are those with a BMI between 30 and 35. The red one are those with a BMI between 25 and 30. And the blue one are those with a BMI below 25. And if you look at this, and these are all heart failure patients, you say, well, I should not tell my obese patient to reduce the weight. Actually, I should tell my thin patient to increase their weight. And no dietary, no dietitian in the hospital, pasta and pizza together every day, and so forth. Well, the point is that we have a major bias because if you compare patient by matching by age, gender, left ventricular ejection fraction, peak VO2, the difference disappears. That means that if I have an obese guy with severe failure, I don't want to put him on a bike. I'm scared. And so my patient with obesity, put him on the bike, whereas those with moderate heart failure, and that explains the better prognosis. But again, obesity is a problem, but it's not a function associated with prognosis. And what's happened if my patient has anemia? You know that patients with a hemoglobin concentration below 12 have a worse prognosis compared to patients with a normal hemoglobin concentration. And this is something that you have to take care. I cannot go into detail of the physiology meaning of anemia, how much it counts in VO2, because I don't have the time. But if you come to our courses in Milano, you will go inside all these details, and you have to realize that if your patient has 10 grams of hemoglobin and the VO2 is low, maybe it's not the cardiac failure, but it's just the anemia who is the determinant of your low VO2. And what's happened if the patient is treated with beta blockers? You know, we have many patients treated with beta blockers, and they say, well, my exercise performance is low because of beta blockers. Well, this is not true. Let's see what's happening in heart failure patient with and without beta blockers. With beta blockers, beta 1 selective versus beta 1 and beta 2 blockers, and patient with high dose beta blocker with low dose. In the upper slide, you see that patients without beta blockers, these ones, have a much worse condition, prognosis, otherwise cardiovascular death, organ, heart transplant, and LVAD. Those with selective or unselective beta blocker have the same prognosis, but please remember that in this case, there has not been done a match between patient characteristic and beta blockers, but was just by chance. And in the third graph, you see that the patient who have a high dose beta blockers, and with a high dose, we say greater than 25 milligram of carvedilon equivalent, they have a much better prognosis than patients with intermediate or low beta blocker dose. And is the presence of beta blocker affecting the mean of VO2? And the answer is yes. These are all patients who are potential heart failure candidate, heart transplant candidate, so severe heart failure. If you look the yellow group are patients with a VO2 between 10 and 12 ml per minute per kilo. Those above, this one, are with beta blockades. Those, regardless of the same VO2, are not beta blockade, and the problem is different. The green one are those with a VO2 between 8 and 10, so very reduced. But again, these guys are those with beta blocker, and these guys are those without beta blocker. So again, when you analyze VO2 in patients with heart failure, you have to know if they are beta blocker or not. And what's happened to the renal function? Here we group our population according to low eGFR, intermediate eGFR, and normal eGFR. And these are patients with high and low VO2, but normal GFR. The red are intermediate and again high and low VO2. The black one are poor kidney function, high VO2 and low VO2. That means that you cannot take the VO2 alone, but you have to take it in the concept of the entire patient, considering everything. And you have to go to a multi-parametric approach. And so we are suggesting that the metabolic exercise data combined with cardiac kidney index, the MECI score, is the most useful one, and it is on EC guidelines as something that needs to be done. It's been built through a complicated analysis, statistical analysis, and at the end, 6 parameters came out, starting from more than 60, 2 derived from cardiopulmonary exercise testing, peak VO2 and VEV-CO2 slope. And then we have hemoglobin, sodium level, left ventricular ejection fraction, and kidney function. And as you can see, we have an ORC curve with a value of 0.8, which is the highest value never reached in patients with heart failure as prognosis. You can easily find, if you go on internet, you digit MECI score, you find this score and ask you peak VO2, VEV-CO2, and so far, and you came out with a score at 2 years. We compare it with the Seattle heart failure and the heart failure survival score, and the MECI score was always better at 2 and 4 years. And you have to remember that there is not a single parameter which is as strong as the MECI score. This is a MECI score, and these are the single parameter which combined give you the MECI score. So you need a multi-parameter approach. This has been validated with different studies, and it's been published a recent international validation with patients coming from China and Europe outside Italy. And what's happened is that the MECI score remained very strong predictor up to 10 years, and actually the AUC was even greater than that we were able to identify in our patient. It is above 0.85. However, a number cannot be this for all your life. you need to repeat the test. You need to repeat the cardiopulmonary exercise test at least once a year. And here is what you find if you repeat the test after 1 year and you have an improve in the Mackey score or a reduction in the Mackey score regardless of its value. Those who improve have a much better prognosis than those who reduce the Mackey score. And this was something which happened in an holistic way, because left ventricular ejection fraction, peak VO2, VE VCO2, kidney function, they always go in the same fashion. They always go in the same direction. And so you cannot imagine somebody who improves VO2 but not VE VCO2, not anemia, not left ventricular ejection fraction. And here you have the data one by one. Only only a sodium level is not a good stuff. Now, in the last 5 minutes, I would like to, before the question, I would like to bring you where is the future. You know, the future for patients with exercise and cardiopulmonary exercise testing is to know what is going on. And this is very difficult because you have your patient in front of you, and the patient you exercise and you tell, well, this is your prognosis. But you know, the prognosis may be not too bad, good, whatever, but you need to know what's happening to your patient. And so we built, via artificial intelligence, an analysis starting from almost 8,000 patients, and we have a control group of 800 patients, and we did a data set consolidation without knowing anything. We analyzed 43 clinical variables starting from 51, and these 43 clinical values, we didn't know even what was a clinical value. We know it was a clinical value. And then we did what is called a topological data analysis. We were able to classify patients according to the same characteristics, and then we moved to a supervised analysis. But the first 2 steps are totally blind. We don't know anything. It's the computer who does everything. And he came to us with this 19 clusters or 19 family of patients with the same characteristics. And again, there were 43 parameters. So not only peak VO2, EOV, but also the reason of the heart failure, ischemic heart disease, the EKG, the atrial fibrillation, and all these things. And you can categorize patients with poor prognosis, and you can see that patients with a worse prognosis, these 2 groups have a very poor prognosis. But you see here, this guy has a very frequent atrial fibrillation, and this guy has a better, but they have a better left ventricular ejection fraction. This guy have a worse kidney function compared to this. So in each category, in each cluster, you have different characteristics, albeit the prognosis may be the same. And so we were able to build an evolution pathways which start from cluster 16 and arrive at the end in cluster 1 and 2, but following a route so that the evolution of your patient is something that you can follow up, and you have 3 points which are the so-called bifurcation point. When you are here, if the patient moves in this direction, he is going toward a poor prognosis. If the patient is moving in that direction, he is going toward a better prognosis. And there are characteristics. There is the onset of atrial fibrillation, there is the development of blunder branch block and stuff like that. And then you have 4 ending clusters. And you have a time to develop these things. But the most important thing is that all these clusters are associated with a prognosis. And if you increase in your pathway, you follow a pathway, you have to realize that your patients are going toward an evolution which can be good or bad or intermediate. This was the validation, which has been done with 2 different populations, and the validation was very, very, very good. And this is the time needed to evolve. And the time needed is measured in what is called pseudo time. It may be also very long. And this is the analysis that show you in each cluster that the study cohort and the validation cohort have exactly the same results. But this is the very last slide of mine, and I would like to bring you through here. On the left-hand side, there are patients studied several times. And as you can see, the red one are those who have a worsening. And the worsening means change from one cluster to another cluster, but always following a roof, always following the same path. Those who improved, the blue one, did the same thing, but on the reverse. So it's like I have a failure, but I have a path to follow, to evolve. Either if I am improving, going back, or even if I am deteriorating, going forward. On the right-hand side, there are patients treated with most effective drug, like introduction of Entresto or introduction of SGL2. And you see that those who improve, the blue one, again, they follow the path. So in this way, we have the concept that there is a history for all our heart failure patients, and there is an evolution. But you can interfere with evolution going in one direction or in the other direction, but the route is already defined. And this is very important. And the major parameters who are driving this are exercise-derived parameters, peak VO2 and VEV-CO2. I know this was a difficult lecture. I know this has a bunch of question marks in your mind. However, that just tells you there is cardiopulmonary exercise testing is the only holistic way we have to assess the body function, and it is the best technique we have to understand what is going on. And I would like to thank you and remember you to go to see the Duomo in downtown, because that is much better than listening to a talk like this one. Thank you very much.
Thank you, Professor Agostoni. I do not totally agree with your what you last mentioned about it's sometimes also good to listen to you. And to be honest, I will never be stressed again if you send me 70 slides for half an hour. You were right, I should not worry. Again, excellent presentation. I think it's a different look at CPET interpretation, at least for me. And as Professor Agostoni says, I assume there are questions, so we have microphones, so please ask your questions. There.
Excellent presentation, as usual, Dr. Agostoni. And I have a question. You said that the double anaerobic threshold, it's a very important thing to look at the cardiopulmonary exercise testing in these patients, and is also seen in healthy people. But I don't know, in this double anaerobic threshold, do you think it could be more abnormal or something in respiratory chronic diseases? And
okay, the point is that the double anaerobic threshold, we believe, is due to a delay in the chemoreceptor response. If you have a patient with oscillatory breathing, the anaerobic threshold is not analyzed if the oscillations stay up to the end of exercise. So the anaerobic threshold doesn't exist in this type of patient, so we cannot assess. Patients with oscillatory breathing were excluded. I have no data as regard all the patients with respiratory diseases like COPD and stuff like that. And actually, since you are an expert, you should look back to your COPD patient to see in those who you identify the anaerobic threshold if they have a double anaerobic threshold or not. And I think this is already a very nice study to be done. But remember, I am a cardiologist and I do not see so many COPDs. But that is a very good point.
Thank you.
Another question?
Doctor, when you say that there are differences between women and men, and you did study that, do you separate women who are receiving replacement therapy with estrogens, or because we know that estrogen and replacement therapy increases vasodilation, production of nitric oxide. So did you did that on your study?
No, this is a very good point. We are working on a reanalysis of evaluation of patients, of female patients. We have now 1,500 ladies with heart failure, but I do not have the information as regard replacement therapy, and it is possible that replacement therapy will enhance the difference between men and women, but I don't know.
Okay. And question
Considering that half our patients have heart failure with preserved ejection fraction, can you comment on use of CPET in prognostication for those patients?
Can you repeat?
Heart failure with preserved ejection fraction.
Yes.
CPET parameter.
Yes, we use. I have a paper accepted last week on European Journal of Heart Failure in patients with middle range, and they are totally different than those of reduced ejection fraction. The preserved ejection fraction patient have a different behavior. They are characterized mainly by changes in VVCO2, because these patients develop high pressure in the pulmonary circulation, and this acts. I have a paper with my friend from Austria, Wilfred, who is here, on amyloidosis patient. And in this patient, ejection fraction is usually normal. And this, in this study, we compare patients with heart failure and patients with amyloidosis, and we compare with patients with the same age, left ventricular ejection fraction, and peak VO2, and the difference was VVCO2. In the amyloid patient, the VVCO2 was much higher. Again, we believe because the pressure in the pulmonary circulation goes up very fast, and that influences the VVCO2 behavior. But he will send out the paper next week, something like that.
Okay, thank you. More questions?
Oh, thank you for your presentation. I like the cluster model. Can you tell me, how do you use the cluster model in individual patients? Is there a difference in treatment between the different clusters?
Yeah, well, the cluster model is built using 43 variables, okay? Now, you have a patient which is in cluster 12, okay? You know that for going to cluster 10, he will reduce, let's see, VO2. So if you follow your VO2 and you see that it's going this direction, you have to change the treatment according to VO2. Or maybe going from 12 to 10, you have a worsening of anemia. And so you have been focused on anemia. But this is something that the computer will tell you. Pay attention to. But this is a major change in the way we are seeing the patient. The patient is now not a single individual, he is a cluster, he's a family of patients with the same characteristics. And we know in which direction he is going. So we have to do our best to move from 12 to 13 and not from 12 to 10. But once you are in 12, if you don't do anything, the destiny is this, which is better than going to cluster 1 and 2. Okay?
More questions? We've still 5 minutes. Otherwise, I have one question. I see, of course, that VCU slope stays as an important prognostic value, so it's about hyperventilation. Why do the heart failure patients hyperventilate? Is it too high dead space? I don't think so, because our arterial CO2 is too low. Or is it sympathetic drive, overdrive?
No, the hyperventilation in heart failure patients is mainly due to hypersympathetic tone. So it is an increase in metabolic muscle and chemoreflex. And the study on anemia was extremely interesting. If you have somebody who is anemic with 10 grams of hemoglobin, in this case, VVCO2 is no more prognostic because the oxygen delivery to the muscle is reduced regardless of cardiac output. And the metabolic reflex are activated regardless of the severity of heart failure. And so VVCO2 is no more a prognostic data. So again, you have to have an holistic way. The chemoreflex response, the metabolic reflex response cannot overwhelm, for instance, anemia or renal insufficiency. So you always have to have a global visual. And CPET is very good because it's the only holistic parameters. But I dream that one upon a time you will have to add in your computer age, gender, which you already put, therapy, but left ventricular ejection fraction, kidney function, anemia, and so far, and then you will come out with a true value of your VO2. Because again, if your guy is anemic and VO2 is low, well, so what? I mean, I have a bunch of patients with mitral insufficiency, and I have a surgeon say, I want to operate him, or I want to put a clip. And you say, wait a moment, this guy has a dyspnea. Yes, of course, we have to put a clip. Wait a moment, this guy has 9 grams of hemoglobin. Treat hemoglobin first. You have to realize that each gram of hemoglobin, if your cardiac output is 10 liters, means 100 ml per minute of VO2 reduction. So if you have 5 grams of 10 instead of 15, so 5 grams of hemoglobin less, and your peak exercise cardiac output is 10, which is good but nothing of fantastic, your VO2 is lower than half a liter. And all these calculations can be done in cardiopulmonary exercise test. And actually, when you are going to be a little more advanced, you will measure cardiac output with your VO2 non-invasively. There are several techniques possible. And so that you will put VO2, cardiac output, a VO2 difference on the same graph. And this is a step forward to a more integrated vision. Another thing which I never understood, you have patients who have shortness of breath during exercise. And there is a bunch of colleagues of mine say, well, we cannot exercise, he is shortness of breath. But he is exercising every day anywhere. So exercise even those with severe dyspnea. Exercise everybody. There is nobody who lives on a chair. Okay, nobody knows, but almost nobody lives on a chair. They have to move to the bathroom, so they have to do an exercise. The important thing is that you reduce the workload you apply. So you have, we have cases where we put 2 watt per minute. So in 10 minutes, 20 watt, nothing. But for this guy, we can have a complete test and understand what's going on. Remember, exercise everybody. The oldest lady we exercised, she was 98 years old. And she
Sorry, we have one question there.
Oh, sorry.
I don't want to interrupt, but...
Hi, Prof. So I just want to ask you about the concept of chronic anemia and mitochondrial preconditioning. So we see it in ischemia, and if you've got a chronic anemic value from whatever underlying condition like renal failure, a hemoglobin of 9 or 10, is there any benefit in increasing that hemoglobin preoperatively to optimize VO2, or will the mitochondria have adapted to that hemoglobin level?
Well, this is a very good question. The point is, let me generalize. If I have in my mind the Fick equation, VO2 equal cardiac output plus AVO2 difference. I improve my cardiac output by anyway, or I improve my AVO2 difference because I correct anemia. Is this directly reflected in a change in VO2? Well, unfortunately, the answer is no. Why is that? Because between VO2 cardiac output and AVO2 difference, we have in between distribution of blood flow, which is a major issue. I have a paper submitted showing that in patients who undergo different type of treatment, like mitral clip, cardiac rehabilitation, biventricular pacemaker, the change in cardiac output is not reflected in the same change in VO2. But there is a redistribution of blood flow so that you cannot see these major changes. But this is a very long story. It's, you see that VO2 is one number, but again, you have to see it inside cardiac output and AVO2 different. But you are totally right. If you correct anemia, some increase in VO2 you will see, but not as much as by calculating it, keeping everything constant, because it's not constant. Distribution of blood flow is a major variable in exercise.
We are on time. Can you please go to the next slide? Thank you again for your presentation. Thank you all for being here and also the interactive, all these questions. But we try to stay on time. Again, thank you.